Hello, everyone, and welcome to the Lytham Partners Summer 2022 Investor Conference. My name is Adam Lowensteiner, Vice President of Lytham Partners. Thank you for joining us here today with a panel discussion co-hosted by Aurora Spine, ticker symbol of ASG, that is Alpha Sierra Golf on the Toronto Venture Exchange, and ASAPF, that is Alpha Sierra Alpha Papa Foxtrot on the OTCQB in the US. Today's discussion is titled Aurora Spine Simplifying the Complex, a focus on the zip, one of Aurora Spine's main products. We will dive into questions in a moment, but one reminder is that Aurora Spine is available for one-on-one meetings. If you have not already signed up, please email me at lowensteiner@lythampartners.com or visit www.lythampartners.com/virtual and click on the one-on-one meeting request button. Today's joining us are Trent Northcutt, CEO and co-founder of Aurora Spine, and Dr. Stephen Falowski, a neurosurgeon at Advanced Surgery Center of Lancaster. So before we begin the discussion, I would like to have each of you introduce yourselves and provide a brief description of your background. Trent, we could start with you and then pass it off to Dr. Falowski.
Thank you, Adam, and thank you, Dr. Falowski. It's a real pleasure to be here today, and I appreciate everyone's time. My background is I'm the co-founder and president and CEO of Aurora Spine. We started out as a privately held company, but quickly went public on the Toronto Exchange. Much of our capital investment came from north of the border. We've been honored to be on the TSX Venture Exchange since virtually, the first year out of the door as a company. Since then, we've been able to commercialize over 16 different products introduced into the company, have over 8 points of patent in the company, and continue to develop intellectual property and create new technologies for the company. And we collaborate with amazing people like Dr. Stephen Falowski, who I will allow him to introduce himself. Dr. Falowski, thank you so much for joining us today here at Aurora. And tell us a little bit about yourself.
Well, thank you, Trent. So I am Stephen Falowski. I am a functional neurosurgeon out of the Philadelphia area. I specialize in complex spine, but also minimally invasive procedures on the spine, as well as what we call neuromodulation. So uniquely oriented to work with Trent and a company like Aurora, who's developing minimally invasive techniques in addition to normal traditional spinal surgery techniques, which I find very close to home. And it's great to be working with the company.
What got you involved in spine? What was the thing that said, you know what, I want to be involved in spine, Dr. Falowski? What was that? What was that aha moment for you?
Honestly, the aha moment was that I realized actually as I was going through my neurosurgery residency, which I've always wanted to be a neurosurgeon, but as I was going through my residency and doing a lot of these very large, complex spine procedures, I realized that a lot of the outcomes weren't as great as we wanted for some of these more complex cases. And patients and the physicians were looking for more minimally invasive opportunities to try to have the same efficacy or same success rates, but just without the potential side effects or complications that can come with these much larger procedures. And that's how I adapted to do what I do now, which is a lot of minimally invasive techniques. And sometimes I jokingly say that my job is to try to keep pedicle screws out of patients and use things like the zip, which are minimally invasive, so that we can do that.
What's really fascinating about you and your career, Dr. Falowski, is that you not only are a functioning neurosurgeon, but you've also been able to create something that many others haven't. You've actually created this bridge between the pain side of the industry in regards to neuromodulation and other types of events that help cure the patient of their pain. And you're also a hands-on, full-blown surgeon where you've done spinal procedures from the top of the neck all the way down to the low back. Can you talk a little bit about that, how you've brought these two together? Because you're very unique in this aspect.
Yeah, absolutely, Trent. I mean, one of the things I'm very passionate about is bridging the gap between interventional pain physicians and surgeons. Right now, for many years, there's been a lot of animosity between the two, and there has not been procedures that actually bridge the gap. It was that previously interventional pain physicians did things like opioid management and maybe potential spinal injections. But then the surgeons took on all the other procedures, which included open spinal decompression and fusion procedures. Up until more recently, there has not been procedures that have been in between, and that's because there hasn't been a collaboration between interventional pain and surgeons. And I made it a point in my career over the last 15 years to try to bridge that gap, to the point that I've actually even written a textbook called Integrating Pain Treatments into Your Spine Practice, so that we can learn how to build relationships with the pain physicians and bridge that gap. That's one of the things I'll just point out for you, Trent, is that I really like about Aurora is the products that you offer are perfectly aligned to bridge that gap where they can be performed by surgeons, but they can also be performed by very skilled interventional pain physicians. And when the interventional pain physicians work collaboratively with the surgeons, we can identify more of these patients.
Absolutely. This is one of the great things that got you and I started. We sat down and discussed the screwless procedure, the Aurora Zip procedure, and you'd had a lot of experience with interspinous devices, interlaminar devices, blocker systems for fusion and for non-fusion. Walk us a little bit through your experience with interspinous devices that have been in your practice a game changer and an option for your patients.
Yeah, so I'll tell you, I mean, other options or tools kind of existed like this, but were never as unique as the Zip. And what I mean is that these interspinous devices were either meant to just be blocking devices or what we call indirect decompression devices, where they meant to just kind of try to open up the space, but then they don't fuse the spine or prevent excess movement, which doesn't stop the pathology from happening. So there's a lot of limitations to using those, in the sense that when patients had more severe pathology, more severe symptoms, if they had degenerative changes or arthritic changes in their spine, those devices would be a potential to fail. But then on the other end of the spectrum is we had these very large invasive interspinous fusion devices, which required much more open procedures, much more extended dissection and recovery time for the patients in order to bridge that gap. What was nice and I thought very unique about Zip was that it was in between those two and was able to get the job done, meaning it can perform the decompression or that indirect blocking that we use, but it can also perform the fusion. And it's able to do that through a very small, minimally invasive incision that also interventional pain can do, which is the first time we've seen an interspinous fusion device that can be done by interventional pain and be done safely by interventional pain.
Yeah, and I'll embarrass you just a little bit because you and I have been out and about. We have this is Chrissy Ramey on the phone here. She's also on the call, and she's the director of our clinical education. And we've been out on the road quite a bit doing these labs. And you're in this video that's going to be playing behind me here. You've been on the stage many times for us, and we couldn't be more grateful for that. Once you walk the audience through a little bit of this, as we're presenting the didactics to the lab, and as we're presenting the actual hands-on lab experience, before we get into the inner depths of the Zip device and the multi-center study that you've been passionately working on with us, you're right here on stage, as you can see right here behind me. Walk me through a little bit of your didactic sessions explaining the procedures to these doctors.
Yeah, absolutely. So we've been running a lot of these national and also regional courses, but one of the things that we feel that's important, and when I came on board with the company, was education. And rather than just train the physicians on how to do the technique, we teach them also about patient selection. Where does this actually fit into your practice? How do you integrate it into your practice so you can find more patients for it? And then we also even talk about things like complication avoidance and how to take care of these patients for the long term. So we organize these courses that they have didactic sessions to address all those issues. And then we finally put the physicians into the lab so they can get a hands-on to learn how to put these in. We could very easily just take an hour to show physicians how to put this in and how to do the dissection and how easy it is in a minimally invasive approach. But I think it's more important that we give the fuel for these physicians to go back and feel comfortable doing it. And that's what these courses are designed to do. Talk about patient selection and how it fits into your practice so that they can come back and feel comfortable integrating it in their practice.
And I know I've been hands-on with you. You and I have been, elbows deep in specimens. We've trained well over 300 physicians since we first met. These doctors have been really excited and really engaged on how this technique could work in their practice. And what do you find that the outcomes now that some of these peers and colleagues that you've been speaking to, what have they been telling you?
It's great. I mean, all the physicians who have adopted the therapy and taken it back have done extremely well with it. They've had very high success rates. But what I think is probably the most important is they've had a very great safety profile, meaning we have not seen complications come with this device. In fact, actually, we published a paper with 3-month data where with only the interventional pain physicians performing the procedure, there was a 0% complication rate and a very high success rate of greater than 70% for pain relief for these patients. So what's nice is it's been adopted very well. It's been taken very well into the interventional pain community, and they're doing a great job with it. It's important to have efficacy, but it's also important to have safety, and we have that now.
Yeah, you were very insistent early on that you wanted to have evidence-based presentations, evidence-based medicine, evidence-based products that when these doctors have their hands-on experience, that they walk through the didactic course, they walk through the experience, and we talk about potential complications. We talk about the ability to treat the patients, and we talk about the coding, the reimbursements. We also walk them all the way through where they're actually hands-on with these cadavers. And I'm so glad that they've been able to reach out to you and speak to you and talk to you one-on-one, because I know you've taken phone calls, you've answered emails, and of course, you've been part of these big, large presentations. So now with our multi-center study that we've been embarked on since the end of 2019, when we were coming out of the COVID era, we were working on this multi-center study. Why don't you walk us through a little bit about what we were looking for in our multi-center study and how this was going to be effective as a training protocol and as a multi-center study locations that we selected around the United States?
Yeah, absolutely, Trent. And you said it spot on. It was very important to me to have evidence-based medicine for what we do and be able to show that it was safe and effective moving forward. So the trial that we have ongoing now is a multi-center prospective trial. So we're prospectively following these patients forward, which is some of the highest level evidence we can generate. We're choosing multiple centers around the country, and we're dividing them mostly actually with interventional pain physicians, but also a few surgeons like myself in the study. And we're looking at many different endpoints. So historically, most studies have looked at just pain scores to see how well the patients do in reference to their pain, which we know that these patients are already doing well with that. But some of the other things that we're looking at in the study is actually functional outcomes, how well these patients are performing physical functions, how well they're sleeping afterward, things that are demonstrating that they actually have an improved quality of life. And then we're also looking at a safety aspect of the procedure, make sure that there's as close to a 0% complication rate as we can have. So what we do is that we've trained physicians around the country, and then those who are adopted would be eligible to be part of the study. But we do have a screening protocol in place where these physicians have to perform 5 procedures at the least and also feel very comfortable with it. And then once we get through that screening protocol, they can potentially be part of the study. And right now we're looking at, I think we have about 15 sites that are enrolled in the study. We can do as much as 20 sites, but we actually have some very good enrollment now, especially now with the post-COVID era, and we really got the study up and running. We're about halfway enrolled at this point, and we also are presently publishing and just submitted for publication our first 3-month data on the data that came from the first 3 months of the study. So I can tell you that without giving it all away, it's actually very exciting data that shows that it's very safe and effective.
Yeah, without giving it all away, walk us through a little bit of the data that you can talk about, and how has it affected your practice, and what do your patients have told you?
Yeah, I can tell you based on even some of the retrospective studies we've looked at, which means some of the first patients that we've enrolled and we decided to publish on them and look back on them, we're actually maintaining great pain relief for these patients, anywhere from 70 to 80% pain relief, which is very difficult in the patient population that we're trying to treat, because a lot of times the patient population that we're treating is those who don't have surgical options. They may not be a candidate for a large open surgical procedure, or these are also patients who are suffering from long-term stenosis or arthritis in the spine or long-term chronic pain. So they're some of the most difficult patients to treat. And what we're seeing is 70 to 80% pain relief in these patients. But more importantly, what I look for as a surgeon, especially when we're bridging the gap with interventional pain, is that we're actually seeing an extremely low adverse event rate actually with these patients. And in the paper we're publishing now, we actually had a 0% complication rate related to the device, which shows that we're actually doing a great job of training these physicians, and the physicians are doing a great job of adopting the therapy.
Another thing that's come up in recent conversations that I'd like for you to touch on is that we are now hearing back from many of the doctors that have been part of our training courses and that they participated at and felt that there was an absolute need for them to get away from more opioid use and that they were able to lower their opioid use. Can you touch on that for a moment?
Yeah, absolutely. Without giving out the exact numbers and all, we showed that the majority of the patients in the study either decreased or eliminated their opioid use. And I can tell you one of the things that we actually even just look forward to in the chronic pain space is that we actually just want to stabilize even some of these patients, because they're on a track of just endless increasing in the opioids, because the opioids they become used to, and eventually they need more doses of it, and then more of the opioids or different opioids to try to overcome that. So for us, a lot of times it's considered a success if we can just stabilize these patients. But what we're actually seeing now with the ZIP device is that we're not only decreasing the opioids for a lot of the patients, we're actually eliminating them from some of them.
That's fantastic. When we walk through, I've been playing the slides a little bit behind me, but I'll go into some of the slides here. So my screen's going to turn off for a second here, and I'm going to hit share. And it has to blow up a little bit. Let me know if this is playing right. Adam, you can tell me if I've got it right or I have to switch it.
So far, looks good.
All right, we like to steal this tagline from Leonardo da Vinci, that simplicity is the ultimate sophistication. So let's talk a little bit about the design of the implant. The two implants that are primarily being used, the one on the left is the ZIP LP, which stands for low profile, and the ZIP 51, which has been specifically designed for L5S1, although both implants are 510K cleared with the FDA from T1 to S1. So once you walk through the implant a little bit, Dr. Pawlowski, the ZIP LP and the design side of it from your side, when you're in surgery, how that the implant performs for you.
Yeah, absolutely. So what you're seeing here is if you look at the ZIP LP and then also the ZIP 51 on the right side, they're very similar. The difference between the two is that the ZIP 51 has a much lower profile on one end of the device. And the reason being is when you take care of L5S1, or the very bottom part of the spine where it meets your sacrum or your tailbone area, the tailbone has a very small spinous process, so there's not a lot to grip onto. So the ZIP 51 was designed with that much more tapered end on one side so that we could actually adhere it to the sacrum. But the way the device works, if you give it a close look there, is you see a barrel that's in the center of the device. Now, what's interesting is with that barrel works as an indirect decompression. So if you can imagine the spine has bones that are sticking up called your spinous processes. Those are the bones you feel if you rub your hand down your back. What we're trying to do is open those spinous processes because it opens the canal where the nerves are. That's what that barrel does. It's put in between the spinous processes, one to work as a blocking device so you can't clamp down, but also as what we call indirect decompression, which means we indirectly open up the spine. What we also do is through the barrel of that device, we put bone graft material, which will help to create a fusion across the two bones, the spinous process of one level to the spinous process of the other. So what we're actually doing is now we're actually fixating or fusing the level open so that you can't clamp down on the nerves. What actually leads to a lot of this stenosis or the arthritis in the spine is a constant abnormal movement of the bone. And when the bone rubs on each other, that's when you get overgrown bone, overgrown ligaments that actually crush the nerves. By fusing it and having that fusion across the barrel there, it actually prevents that abnormal movement. So you prevent the pathology from progressing on. The way we get the barrel to hold in place, which is a very unique design, is what you see is the spikes on either side. Those spikes on either side are able to clamp into the spinous process or clamp into the bone and hold it in place. So what you see here on the X-ray images is that we take the device, we put it as close down to the canal or that opening in the center of the spine as we can to hold open that space, and then we clamp it there so it's held there, and then eventually the fusion comes across to the device.
One of the slides that we show that is not meant to pick on anyone or anything is that we show that this comparative analysis, Dr. Pawlowski, was actually a slide that you present that talks about the difference between the mild, the Vertiflex, and the pedicle screws, and of course what the Aurora Zip device does. Can you touch on this, please?
Yeah, absolutely. So these are looking at the options we've had in place for the last, some pedicle screws for the last 20 years, but also mild and Vertiflex, which are two minimally invasive procedures that have been around anywhere from like 5 to 7 years, maybe as much as 10 years for the mild procedure. What the mild procedure is a minimally invasive way of doing a decompression or removing some of the bone that's on the spine. The problem we have with that is it's just meant for what we call central stenosis, only stenosis that occurs in the center of the canal. It doesn't take care of the nerve roots off to the side or the spine off to the side, what we call lateral recess or foraminal. So it's very unique. It's very specific in what you can treat with it. The other thing that's very important is if there's any arthritic changes. So what you see there is DDD, it's degenerative disc disease, or spondy, where it says spondy greater than 2. These are all signs of severe arthritis. If there's any signs of arthritis or degenerative changes, we usually cannot perform that procedure. The Vertiflex device was an indirect decompression device without being able to do a fusion. So it had some of the similar problems that mild did, in that as soon as you have arthritic changes, degenerative changes in the spine, this device could potentially fail. As soon as the stenosis is just too severe, the device is not enough to work because it's not creating a fusion or opening up that space. It's only indirectly blocking it from clamping down. Now, the one that would be the closest, which I think is quite interesting, is pedicle screws, which is your traditional open spinal surgery. But as we know, doing pedicle screw fixation is a very morbid procedure. I mean, this can be 3-4 hours in the operating room, 3 to 5 days in the hospital for recovery, 3 months in rehab for recovery to fully recover. These are very large surgeries that a lot of patients may not be able to tolerate, especially the same day. And their recovery now is more like 2 weeks as opposed to 3 months from the procedure, and that they have the ability to potentially have the same efficacy or same success rates with this, with actually a lower risk profile.
It's terrific. I'm glad to hear that you walk them through. You've seen it perform yourself. You've seen how the product can be a real game changer for the doctor's practice, real game changer, obviously for the patient, which is the most important person here. Where do you see the future of this going? Where do you see the ZIP implant improving surgical outcomes? What is your thoughts on this?
Yeah, absolutely. I for the future, I just see a massive uptick in the adoption. I think we've been waiting for the evidence-based medicine to unfold, which we've now actually published several retrospective studies. We now have the 3-month data that's going to be published very soon. And then we'll be finishing up our 1-year data very soon in our refined study or our multi-center study. So we're actually starting to produce finally the evidence that we need in our space for this. And I think what we're going to start seeing, especially now with the trainings that we're doing and then giving education to these physicians, that we're going to see a much more large increase in the adoption rate for this. And I think it's inevitable that this is going to happen because not just physicians, but patients are looking for more minimally invasive options. And there's a large amount of patients there who not only they want the minimally invasive option over the open traditional spinal options, but there's also a large amount of patients out there who are older, maybe 70, 80 years old, and have medical comorbidities, and they just can't tolerate one of these large 5-hour open procedures. Now we actually have an option for these patients. So I think what we're going to see over time too is the patients and the indications that we use for it are also going to continue to grow.
That's terrific. Thank you, Dr. Pawlowski. It's been a real pleasure speaking with you today and talking about the ZIP device. We're grateful, you as our medical director of our company, working towards improving the outcomes, improving the science, improving the data. We will continue to drive this forward. We are more than motivated as a company to continue to get positive outcomes with this device, and we're going to continue to prove it and continue to roll out further with this device. Any final parting thoughts that you might have?
No, absolutely. I just think that it's important to leave with that this is where the space is going. For a large time, I mean, I can tell you, even as somebody who does these large open spinal procedures with pedicle screw fixation, we've been under scrutiny from insurance companies, also from patients, that patients want more minimally invasive options. Insurance companies want more cost-effective options with better outcomes. And we're finally starting now as a field to push towards that. And I think it's because we've also learned to collaborate with the interventional pain physicians, because a lot of these patients are actually in their practices. But that would hopefully be my parting thoughts.
That's correct. That's correct. It's an exciting time. We are doing the things. We're doing the collaboration. We're doing the education. We're doing the data share, and we are training like crazy. I know that Chrissy Ramey is running crazy around the country, doing nonstop training programs. Any thoughts from you, Chrissy? Any updates on some of the training programs we have for this presentation? She might have fallen off the call. That's okay. Adam, any other final thoughts from Lytham Partners and for our audience?
No, I appreciate it. Just want to wrap up. Thanks, Trent, and thanks, Dr. Pawlowski, for your time today. It's much appreciated for everyone listening. Anyone would like to learn more about Aurora Spine, please reach out to myself or any member of my team. And everybody have a great day. Thank you.
Dr. Pawlowski, it's a real pleasure always to see you. Thank you again for your time and your presence. I look forward to seeing you in the very near future, and we'll get this going. Zip done.
Thank you.